Hello. So I am getting right into it today because I am so far behind what I intended to do today, and I really wanted to get through a whole host of things. But I am going to make it my intention, as I said before, to continue reading through this book, The Lactation, the pocket guide, the Lactation pocket guide pocket guides for lactation management. I'm reading through it, and I'm so behind. I'm having a protein shake, and this is a full meal replacement shake just because I'm not on a diet or anything. It's just that I need to remember to eat because I'm going through so much today, and this was the quickest and easiest thing for me. So, without further ado, I am going to get into the reading of section 3. So, Section 3, Normal Breastfeeding. Babies love to nurse. Babies are capable. Typically, both nurser and nursling gain relaxation and enjoyment from breastfeeding. Pain and discomfort are not normal, although they are, sadly, common experiences. Normal breastfeeding begins at the time the baby is becoming hungry and the parent responds to the baby's visible hunger signals, also known as feeding cues. These signs begin during the active sleep state, identified by the presence of rapid eye movement, REM, in the baby. Rapid eye movement is like this. When the baby's sleeping, like this. I don't know if you see my eyeballs going under my eyes. But, so my last client, this is their second baby, and they breastfed. And I told them that one of the feeding cues, the early feeding cues, is the rapid eye movement, and that's one of the first times that you can start feeding the baby. Don't wait till the baby's crying, because then it's too late and the baby might not feed well. But this book is probably going to get into that, but let's talk about it. So, as the baby becomes hungrier and more awake, feeding cues are more obvious. The baby begins to bring his or her fist to the mouth, like this. They seek food with the lips, tongue, and head. Smack the lips or extend the tongue, like they go like this. Crying is a very late feeding signal. I think I just said that. By the time babies cry, they have usually become disorganized and do not feed as well. Indeed, they may fret or sleep at the breast after only a few sucks. Getting started at breastfeeding. In the first hours and days postpartum, the dyad learns to breastfeed together and move gradually from self-attached breastfeeding to collaborative breastfeeding. Each dyad moves in a unique pattern. One feeding may use self-attachment and the next collaborative. See figure 3.1 for more information. So, figure 3.1. So figure 3.1 is a chart. The caption for 3.1 says, as the dyad learns to breastfeed together, the self-attached feedings give way to those that are more collaborative. And so the chart is just essentially going from day 1 to day 6, and it shows the difference between self-attached and collaborative. And you'll see the difference from the beginning, day 1, it's more self-attached, and then going through to day 6, it becomes more and more collaborative and less self-attached. I have put a little highlighter here, days that essentially the number of breastfed times a day should be 10 to 12 feedings a day. That is like my moniker, my thing that I tell all families when they're starting. You want to have 10 to 12 feedings a day, and they should be shorter feedings. They'll get into this, I'm sure they will. Breastfeeding moves into a more collaborative style of latching, and breastfeeding after the baby is able to locate the breast. During the first few days, both will become more and more comfortable with collaborative feeding as they learn together. In general, the baby's arms should not cross over his or her body, but rather embrace the breast. In the early days, the baby's hands need the breast during suckling. Hands should not be held away or anchored away from the breast by swaddling. There should not be pain during nursing, not for a minute, and after the feeding has ended, the nipple should not be misshapen, abraded, fissured, bruised, or blanched, all of which signal an incorrect latch. If any pain is experienced, the baby should be gently removed and allowed to relatch. And I did this with my last family. Like, we checked the nipple and it was shaped, it was like slanted. And I told her that actually that means that there's a signal that the baby is not latched correctly, so let's try it again. It's important that when you go to these sessions with your families, that you actually observe a feeding. And this is the best way to gauge, because sometimes their interpretation or the way that they explain their experience, it doesn't give you a full context of what is happening during the feeding. So the next section, self-attached breastfeeding. The healthy baby should be dried after birth and placed on the chest for prolonged skin-to-skin holding, as in figure 3.2. I'll show the picture here. So the whole thing about dried, people can decide not to dry the baby. Some people like to keep all of the fluids from the baby right after the birth on the body and not dry it or clean the baby. This is drying off is really for keeping you safe, so you don't want a baby slip out of your hands or slip off of you. So just drying it so that the baby safely can sit on the parent. The first bullet point, the two are then covered with a warm blanket. Maternal and newborn assessment, eye care, and other procedures are done with the baby in the skin-to-skin position. Note, research shows that babies warm better in the skin-to-skin posture compared with electric warmers. The breast will increase and decrease temperature according to the baby's needs. So this is important because we know that a lot of families are bullied into putting the baby under the warmer, but actually the mom and the baby, their temperature will regulate. So the mother's body will adjust to the baby's temperature, and then it'll keep the baby warm. So there's no reason to whisk the baby away and put the baby under the baby warmer, because the baby will warm better if they're skin to skin. And this is evidence-based, but of course when you're working in hospital settings, it's the doctor's rules and the medical practitioner's rules. So you have to be really firm, or encourage the families to be firm about this. Allow the newly born baby to find the breast and self-attach. This may take more than 2 hours when labor and analgesia has been used, like an epidural. Do not force the baby to the breast. Doing so may stress the baby, decrease willingness to nurse at the next feeding, and cause the baby to place his or her tongue on the roof of the mouth. So, like sometimes, I'm sure, like after birth, you'll see the nurse push the baby's head to the breast. That actually shouldn't happen. The baby will find the breast, but you'll start to notice these things once you put it into practice. Okay. When skin to skin, newborns go through 9 distinct behaviors in their preparation for feeding. These are called Wickstrom's 9 stages. So Dr. Wickstrom did some research on this, and there's a video. When you take the course, they'll go through the video. You'll watch the video and you'll see the 9 stages. But they're listed out here in this book. So the first stage, birth cry. Second, relaxation. Third, awakening. 4, activity. 5, rest. 6, crawling and sliding. 7, familiarization. 8, suckling. 9, sleeping. Collaborative breastfeeding. With collaborative breastfeeding, as the baby seeks the breast, the parent gently assists. The sequence of successful feeding. Ideally, the newborn is held skin to skin or close to the breast so that feeding cues may be observed. When the baby demonstrates cues, the baby is brought to the breast without delay. The breast should fall at its normal angle. The breast should not be held or shaped in the hand. So you see sometimes people are like shaping the breast in the hand. Actually, just let the breast fall down. And TMI alert, so my breast hangs down and the areola hangs down. Instead of trying to bring the baby up, you just let the breast fall gracefully down, and the baby will come to the breast. And I think this book talks about some methods for bringing your breasts or adjusting your breasts if the nipples go down. I wish I had known that when I was breastfeeding my baby. Okay, where was I? When the breast is larger or pendulous, the parent may be tempted to fold the breast upward to see the nipple. Like, so you'll see them want to take the breast, cup it in their hand, and fold it up, but you shouldn't do that, it says. Figure 3-3 shows a more helpful technique, using a roll towel over the breast, which allows the nipple to be seen from above. You roll a towel up, you put it underneath the breast that's about to feed, and then that will help change the direction of the nipple. Collaborative breastfeeding may be initiated when the baby exhibits appropriate cues, including rooting, turning the head, especially with searching movements of the mouth, and subtle body movements, as in figure 3-4. So, figure 3-3 just shows a towel under the breast, like if the nipple and the areola are going down, that helps lift and elevate the breast and turn the nipple. And then figure 3-4 shows some of the body movements. That is a feeding cue. So, talking about the fist, the sucking, all of that. You want to look at that. And that this is before the baby is crying or even whimpering. Increased alertness, especially REM under the closed eyelids, as in figure 3-5. Flexing of the legs and arms and mouthing with little suckling motions, as in figure 3-6. Attempting to bring a hand to the mouth, as in figure 3-7, sucking on a fist or finger, mouthing motions of the lip and tongue. Crying is considered a late feeding cue because it does not usually begin in intact full-term babies until more subtle cues have failed to elicit the parent's attention. This is so important. So especially like right postpartum, when the baby is crying and you're overwhelmed, the parent is overwhelmed. Both parents could be overwhelmed, or sometimes it's just mom there and she's overwhelmed because the baby is crying. This, you as a provider, you as a doula, really focus on those early cues. And I was even telling my sister this when she just had her baby. I was telling her, like, oh, you hear that little thing, or you see that little thing that my niece is doing? That is a feeding cue. So you want to get to her now, because you know that when she starts wailing and crying, it's going to distract you. It's going to become overwhelming. It's going to cause you stress. The baby is stressed, and then the baby may not feed correctly because they're stressed and overwhelmed. So you really, really want to focus on those early cues to start the feeding. Let's see. So these are the images of the rapid eye movement, and I showed you before, like when the eyes are closed and the baby's eyes are moving, under the eyeballs are moving. That's an early cue. And then mouthing is a feeding cue. Baby may make little suckling motions like this, or yes. So watch those. Putting the hand near or in the mouth is a feeding cue. So like this. Yeah. Less mature and more disorganized babies may pass quickly from the state of deep sleep, characterized by no REM, to crying. When using the collaborative breastfeeding strategy, the baby is supported by the frame of the parent's body, especially arms, hands, and torso, which provides the support needed to keep the baby at the breast. The parent finds a comfortable posture and makes the breast accessible to the baby. The baby is allowed the freedom to achieve pain-free suckling with maximal milk transfer. The baby is near the breast. The baby's shoulders are supported at the base of the neck, as in figure 3-8. So if you see the nurse holding the baby's head and pushing the baby to the breast, no. Support the neck, because I'm sure that it'll get to it that the baby's head needs to fall back and then attach to the breast. Not like you don't force the head onto the breast. There should be no pressure against the back of the baby's head. The baby must be able to tilt his or her head. So just hold the baby's neck. Figure 3-8, it's important that there is no pressure on the back of the baby's head. So in this picture, you'll see the hand is on the baby's neck. The baby's neck, so that the head can tilt back. The baby's body is rotated toward the parent's chest. This may be called tummy to tummy, tummy to mummy, chest at the breast, or chest to chest. The baby is moved towards the breast, lining up the baby's nose at the nipple. The breast is not moved to the baby. Doing so may distort the ducts and impede the natural flow of milk. Rather, the breast should lie in its normal position and the baby be brought to the breast. Starting the feed with the baby's nose opposite the nipple. Excuse me. Assist the baby to orient to the breast via a well-developed sense of smell and aligns the mouth at the breast when the baby's head tilts back. As the baby's chin comes closer to the breast, he or she will gape, opening his or her mouth very wide as the head tilts back, as in figure 310. If the baby fails to gape, repeat this maneuver. So baby's head's going to fall back and like this. And then that's when you're going to put the bottom of the breast, not nipple, you're going to like put the bottom of the breast into the baby's mouth and then allow the baby to attach. And then this is what it's showing. You really have to see it. And when you take a course, if you take the breastfeeding course, they'll walk through like how this actually happens, and you'll see videos of it. Like, it's really hard to see it through the book. The book is really for the reference. So figure 311, the tongue takes up the lower half of the mouth. The nipple should be positioned in the top half of the mouth. So look at that. So basically you don't want the baby's tongue to be at the roof of the mouth. It actually needs to be open so the nipple can be at the top of the mouth. Consider an additional session of skin-to-skin holding to improve the baby's motor state organization for the baby who fails to gape or nurse. It is important not to push the nipple into the baby's mouth. So, like, sometimes I see moms taking the nipple and, like, shoving in the mouth. Actually, no, that's, like, a recipe for injury. Doing so is unlikely to result in optimal positioning of the nipple or appropriate compression and release of the breast and nipple tissue during suckling, and will likely cause pain, nipple damage, and slow the flow of milk. The head tilt allows the lower lip to seal the breast first, followed by the upper lip. And I highlighted this because that helps me remember that, like, when I'm looking at the breastfeeding, the mom, like, breastfeeding, I'm going to make sure the lower lip is sealed and then the upper lip. In this position, the nipple feels the open part of the baby's mouth. The baby's mouth will appear off-center when compared with the areola. That is, the baby's lower lip will be against the breast much farther from the nipple than the upper lip. This is referred to as the asymmetric latch, as seen in figure 312. The baby seals to the breast and begins to suckle rapidly. Perhaps 8 or more sucks to 1 swallow at first, then shifts into a pattern of 2 sucks to 1 swallow or 1 suck to 1 swallow. So it's like this: suck, 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 swallow. And then suck, 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 swallow. And then suck, suck, swallow. And then suck, swallow. Like, it will vary, but it seems like this is what this is explaining. And when you take the course, they'll go more into depth with that. This pattern changes during the course of the feed, with the periods of 2-to-1 or 1-to-1 reflecting times of greater milk transfer. These periods are interspersed with more rapid sucking sequences and occasional rest periods. After the colostral stage, the baby can transfer several ounces of milk in very few minutes when appropriately latched and hungry. There is no right length of time to feed to ensure adequate milk transfer. I'm going to highlight that for myself. I didn't highlight it before, because a lot of times parents will ask me, how long should they breastfeed? And I tell them, like, it's not about the length of the time. It's you have to look at the cues and also feel your breast to see, like, if it's been emptied, and also look at the see if the baby feels adequately, like if they're not fussing. You really need to be aware of that. Actually, I want to show this image again because this. The baby is positioned asymmetrically at the breast, but also the mouth is wide open, so it's 140 degrees or wider. I think it's going to go into this, the latch. If not, it will go into it. I'm just not sure when. But the baby is not like this, but it's like this. wider. Like, I can't open my mouth that wide. Um, okay, so there is no right length of feed to ensure adequate milk transfer. So 20 minutes, 15 minutes, like, no, don't get hooked up on the numbers. Just make sure that you're feeding at least 10 to 12 times a day. However, babies with consistently short, less than 5 minutes, or long, more than 20 minutes feed should be assessed to ensure adequate milk transfer. So again, like if your families are saying that they're feeding it for over 20 minutes, they may not be effectively latched, and so the baby may not be getting a sufficient milk transfer. So you really need to observe and watch the feeding. In this figure, there's an image here. When the baby has had enough of milk, the hands and body are relaxed. So this shows a happy baby. You ever see those images of the milk junk babies where they're just like laid out like that's a happy baby? They had enough milk. Breastfeeding sessions are best ended by the baby. When the feeding ends, the baby is relaxed, and then, as in figure 313, which I just showed, the arms are floppy, the brow is smooth, and the toes are curled. The ultimate proof of the success of breastfeeding is a baby who is responsive and interactive, growing well about an ounce a day after the 5th day. I actually highlighted that because a lot of parents will ask me, how much should they be growing? Even though they're going to the pediatrician, they want to hear from the doula what is sufficient growth. And it's about an ounce a day after the 5th day. The baby will lose weight, but it depends on the context of the birth. Like if they were pumped with a lot of fluids and then they had the epidural, like all that's going to impact how much the baby's losing after the birth. So hopefully the baby's being weighed 24 hours after and then assessed before they leave. So growing well about an ounce a day after the 5th day and producing at least 6 wet and 4 dirty diapers a day starting on day 4 and counting into the early weeks. See Appendix 1 for more specifics about what is expected. So the appendix is going to be your best friend. As you see here, I have lots of tabs here because I refer back to the appendix to look for specific details when somebody's asking a question. But just note that it's 6 wet and 4 dirty diapers a day starting on day 4. Oh, and that's the end of section 3. So I thought that was going to take me a little bit longer, but yes, I was able to get through that. I feel good about it, and so I'm going to head off to my work day. Thanks for watching. I hope this was helpful.